Perfect. So I'm Sophia Zabadayev. I'm one of the ultrasound fellows. And today I'm just going to be talking to you about SIM and ultrasound education. So our objectives for today, we'll talk about what SIM is, a little bit about the history of SIM, limitations of the use of SIM, my project, and then just a couple of high fidelity SIM models to end with. And then Ajit will kind of carry on the discussion of SIM and go a little bit more in depth about high and low fidelity SIM and more uses. So what's SIM? So technically the definition is that educational simulation is a teaching method that tests participants' knowledge and skill level by placing them in scenarios where they must actively solve problems. The instructor will define the parameters to create a safe environment for hands-on learning experiences. So there's many things that we do in emergency medicine that you don't want to do for the first time on a patient. For example, if you're doing a resuscitative hysterotomy, or otherwise known as a perimortem C-section, you have a couple minutes to perform that after the patients get to the ER. And so you don't want to be thinking, what equipment do I need? What direction do I cut? You want to have some kind of muscle memory built in after having practiced this before, so you know what you're doing and feel a little bit more comfortable. Even more routine things that we do, if you've never intubated before, never done a central line, you want something to practice on that's not a patient, so you don't walk in with your eyes, bulging out of your head, feeling terrified for that first time. So SIM can be super useful in these situations. Okay, so the history of SIM. So the furthest history that I could find dated back to 18th century Europe. There was a lady called Madame Coudray who served as a midwife, and she worked with OBs and midwives throughout rural France to teach SIM, particularly in the use of forceps for deliveries. So they made these really cool models. They're like on display in museums now, to try to take them around and show them how to use forceps to stop bleeding. As I said, it was mostly in rural France where they didn't have access, and it really helped the poor populations where they didn't have any education or knowledge in regards to bleeding surrounding delivery. And so this was just the furthest dating thing that I could find all in SIM. Of course, we've come a long way since then, but I just thought it was pretty cool. History of SIM and ultrasound in particular, there again isn't great data pointing to one ultrasound SIM model in particular. There was a Lancet paper as far back as the 1950s where it was ultrasound for SIM, again using OBGYN, where they looked for pelvic masses, and they were able to identify babies in that paper as well, like a fetus on ultrasound. And so it's kind of more of a mystery where ultrasound started in SIM and ultrasound started and what the models were like, but that was kind of the earliest that I could find was in 1950s. So what are some of the limitations of SIM? So costs. So there's always costs associated with making models. You can do, low fidelity, high fidelity SIM, and there's ranges of costs in between, but there's always some form of cost, and that has to be factored in, depending on what the budget is for the model you're trying to create. Some SIM models are not reusable, which is challenging. If you're trying to teach a bunch of learners on different days, you have to have lots of models available. Hygiene associated, so some models use live animals, for example, so you have to store them and keep them as hygienic as possible, and you can't reuse them for prolonged periods of time. Some SIM models you can't really transport very well. They're either, really finicky or can get damaged in the process, really heavy, hard to maneuver. So those things must be taken into account. An inaccurate sonographic appearance is also important. I learned on my project that sometimes models can look really cool externally, but when you try to scan them, it doesn't look anything like it's supposed to on ultrasound, which really defeats the purpose. So you have to keep that in mind. And of course, it's time consuming to make models, remake models, go through lots of materials to try to make these SIM models. So onto my project. So My project was targeted at EM residents. The purpose of the project was to teach the fascia iliaca block. For those of you that aren't so familiar with that, it's basically to provide analgesia throughout the lower extremity in patients that have hip fractures. They might need extensive debridement. They could have abscesses, large lacerations that you're trying to repair, and don't want to push a bunch of narcotics. The goal was to increase the comfort level and use of the fascia iliaca block in the emergency department. And that was for residents to feel more comfortable doing so. And the results are still to be determined. It's an ongoing project. And why did I do this project? I wanted patients to have better pain control first and foremost. We found that we're not very good at controlling patients' pain in these circumstances. Of course, we can use multimodal pain control, but a lot of people that are fracturing their hips and lower extremities are older patients where we can't give them lots of narcotics. Otherwise, you know, we're at risk for respiratory compromise and altered mental status. Secondary was the reducing use of opioids. And then lastly, to improve functional outcomes for these patients. So how did I go about my project? So first, recruiting friends and brainstorming. Ajit looks really happy that he's on this slide. He's feeling a little bit famous right now. So it's so important to have a team, you know, of great people to work with. So you can, you know, talk about what's already been done, what may have been done at their institution, and what their experience is with these type of blocks and how they've incorporated it in their practice, and basically try to find the best way to tackle your project. So using people that, you know, have more or less experience, it's really helpful to get lots of different perspectives on this. Next, we decided to do a literature search. So it was important to figure out what we wanted to teach, how we wanted to teach it, what literature was already out there, what the current data shows in regards to best practices for performing this block and teaching this block, to see if there are any current models out there that we could try to simulate or not try to simulate based on how successful they had been, and how we could really build on the current literature. In order to you know, move the education platform forward in general. Next was the IRB application. So I was somewhat spoiled in residency. The projects that I'd been a part of, they had already had an IRB submitted. And then I became involved in lots of research projects. I just didn't have to do this step in particular. So this was a learning process for me as well. And we actually have a phenomenal research team here that helps with this. Tammy's wonderful at really talking you through the steps and what you need to go into that application. It is actually pretty simple when it comes down to it. Some of the things that they do include in it are, you know, who are going to be the study personnel, the inclusion exclusion criteria for your project, how you're going to recruit and screen your subjects, form consent process, your study design, data collection, benefits of doing the project, confidentiality, and then also you include your literature review in the application. For mine, it was based on sim models, which kind of took out a complex component of having to perform this on patients, which made my IRB a little bit more simple.
Bend over, touch your toes. Touch your toes. Touch your toes. Because you're going to play on. Turn around. Touch your toes.
Hey, Steph. I don't think you're muted.
You should wear shorts underneath it. Okay? If you don't want to wear pants, that's fine. But when you bend
Yeah, I just muted her.
Okay. All right. So how
Sorry, guys.
That's okay. So then next we had to create the model. So I worked with Bob and Vanessa in the Sim Lab, who are part of our team there, and they have ample experience in regards to creating these models. And so they were so instrumental in regards to determining what type of gels we should use, how we could make the nerve, artery, and vein as realistic as possible. We went through many iterations of the model because they'd done less ultrasound models and done lots of sim models. And so it was really challenging to find kind of what I alluded to earlier, what looked good under ultrasound versus what looked good in real life. We were able to use these plastic models that they had set up for central lines in the femoral region, which was perfect because that's the same region where we're doing the fascial iliaca block. And then here's just a little video of me scanning one of the models at the time, trying to look at the vessels and the nerve under ultrasound using our butterflies. And to make sure that the needle also was visible, you could see the needle just coming in there next to the nerve, to try to simulate as realistically as possible what it would look like to inject in that region and deposit the anesthesia. I did find on my model as well that I was not able to deposit the anesthetic due to how dense the ballistic gel was. When I tried to deposit it, it all flew back in my face. So it's just another component to think about, particularly if that's something that's really important in your model. That would be a barrier that you would have to try to overcome. For me, the most important component was needle visualization, which I managed to accomplish with this model. And this, again, is just another image of that. And then here, you can see the nerve on the left side of the screen, and then to the right, there's these two kind of circular structures that are supposed to represent the vein and the artery in close proximity. And so I really wanted the residents to be able to see the needle guidance and know where to deposit it. I was not able to simulate the fascial planes. So actually at the top right of that image, you can see what we had tried in regards to creating fascial planes, where we tried layering gel in different levels to try to simulate, different lines in the gel to make it work, but it didn't translate very well on ultrasound. Then we had to go ahead and create pre and post surveys. So for my pre-survey, I wanted to really assess the patient's comfort level with performing the blocks in general, find out if they'd ever done them before, if so, how many. Another important component that I thought was to find out if they'd done any other blocks before. So, sometimes I could reassure people if they've done, look, I've done upper extremity blocks, I've done dental blocks, I've done facial nerve blocks. So this is just another one, so that kind of takes away the fear of what's associated with something that you don't know. And I did find that a lot of the residents had done other blocks. They just generally hadn't done a lot of fascial iliaca blocks. In regards to their surveys as well, I wanted to figure out what the barriers were to performing the blocks, whether they didn't know who would be an ideal candidate for it, or if they didn't know where to find the supplies or what the supplies were that they needed, so that moving forward, I could try to take those barriers away so that, to try to help the residents do more of these in general. Additionally, I wanted to create some standardized education material to send out to all of the residents so that they would know there would be kind of no bias in teaching on the day of, and they would all have the same education in regards to how to perform it, what to look for, and what the structures were. So I made a voiceover PowerPoint so that everybody would get the same education, so there would be no variability in that regard. And the next step was in-person training. So we had the residents come in, it was on one of their conference days, to scan the models and practice their inline visualization of the needle, and look for the appropriate structures. And doing it on a conference day, I think, was really successful because we were able to capture a large audience that day, and have a great turnout. And the next step will be sending out the post survey. So I have to wait a couple months after the education that just happened a couple weeks ago, to see if they've been able to incorporate this into their daily practice and how well it's worked out for them. And then finally, the next step will be writing up the data, becoming famous like some of these rock stars you might know. And so things that I learned from my project is IRB takes time and requires revision. So be sure to, adequately have a significant amount of time prior to when you want to start the project to get this process going. Things that may seem to be awesome in real life or look really cool don't always translate to making really good images on ultrasound. So if your project is ultrasound targeted specifically, be mindful that you will have to go through lots of different steps to try to get the model as realistic as possible. And then that kind of mentioned on the next point too, and really be mindful of faculty and resident time. They're pulled in so many different directions. And so you really want to be cognizant of that and try to, have a short project that's very concise and really is mindful of everything else that they have going on in order for you to have the best turnout too. And then I just want to briefly talk about some high fidelity sim models. Like mine was obviously just something that we're able to whip up here at Loma Linda, but there's some incredible sim models. So this is a Vertimed model. This was launched in 2019, predominantly targeted at OBGYNs, and they're able to do some crazy things with this model. They have modules for doing hysteroscopies, placing IUDs, and they can even do embryo transfer using these models. The next one is a metaphor model where they can simulate fast exams and lots of the common pathology that we see in the ED, which, we see all the time. But if you're working in a more rural area or if you don't have as much familiarity with ultrasound, then this can really be pivotal. And then lastly, this is a Heartworks TEE, which we now have available, which is amazing, where we can put transesophageal echo probes down through the esophagus to look at the heart. And they have some really fancy stuff. So you can look at, they have lots of different built-in models where you can see VFib, you can even see amyloidosis, you can see large pericardial effusions, tons of great pathology, just to get you more familiar with this. So when you see it in real life, when you're doing a TE study, you know what you're looking at. So all of this is just to say, be inspired. If you have a project, don't be nervous. Just see where it goes, talk to people, do a literature review, and see, where you can take your project. And if you need any help with that, we have incredible faculty here, and I'm always available. Ajit will be happy to help. And however we can get you set up and going with your project, we'll be happy to. And then these are my references, and that's about all.
I'm going to be just continuing the discussion on simulation and emergency ultrasound, with Sophia's talk kind of encompassing more of her own experiences with simulation, whereas I'll be speaking a little bit more generally about the types of simulators that are out there, and then kind of how they are influenced by some of the more specific types of learning and how we evaluate learning in simulation and in ultrasound. And so just kind of tying some concepts together. So for the objectives for my talk, it's just going to be kind of a brief overview of some ways that POCUS has been involved in simulation throughout different types of simulators and even homemade models. And then, like I said, some of the more higher level kind of learning pyramids and models, and then we'll put it all together. So just an overview of the ASEP guidelines. So there's a kind of a white paper on simulation in ultrasound that ASEP has put together, which talks about simulation is currently playing an increasingly important role as both an emergency ultrasound educational method and assessment measure. Numerous investigators have demonstrated that simulation results in equivalent image acquisition, interpretation, and operator confidence in comparison to traditional hands-on training. And ultrasound simulators really provide the opportunity for deliberate practice of a new skill in a safe environment prior to actual clinical performance. So the use of this deliberate practice, as we'll go through some literature, it actually improves the success rate of invasive procedures, where it actually really has the most amount of data supporting its use in procedural ultrasound. And it's actually been shown to reduce patient complications, especially in the realm of something like central venous access. It gives us a simulation that gives us a way to expose trainees to a wider spectrum of pathology, like Sophia was touching on. Things like resuscitative hysterotomies, things like even cricothyrotomies, things like that. And also just kind of common variants that are typically encountered during an emergency ultrasound rotation. So blending kind of all this learning created by the flipped classroom, simulation, and live training, it really affects the ability to master a new skill. And then the last kind of thing I want to talk about with regards to the ASEP guidelines is that it also provides a way to really provide a valid assessment measure of each component of ultrasound competency. So if with appropriately designed cases, you can kind of assess someone's ability to recognize indications, demonstrate image acquisition and interpretation, and kind of also how these apply to the ED management. These proven benefits and the reduction in direct faculty time, as many programs have just kind of limited ultrasound faculty, really justify the cost of a high fidelity US ultrasound simulator in the eyes of the ASEP ultrasound section. And so we'll kind of talk about some of those costs that are associated. So how POCUS use really started in being involved in simulation was just through the use of showing clips in simulation cases. So there was so you can imagine your resident going through a simulation case, maybe in a world-class simulation center like we have here, and through for example, undifferentiated dyspnea case, the screen pops up with the image on the right. You're expected to kind of use this image of B lines, which we all know, to kind of guide your clinical management. So this is kind of how it started, and then we'll kind of look at how it's kind of evolved from there. There was a study published in 2020 where a group out of predominantly University of Wisconsin, Sarah Damewood and her group up there, looked at the integration of lung point of care ultrasound into clinical decision-making for medical students in simulated cases. So kind of like we just talked about. They really evaluated the ability of medical students to integrate newly obtained POCUS knowledge into these kind of simulated clinical cases. It was an observational study. The med students were participating in a mandatory ultrasound rotation during their clerkship in the ER. Students were put in small groups. They underwent kind of formalized lung POCUS lectures and some hands-on training. And then they participated in kind of the exact case that I talked about, simulated dyspnea cases, kind of just being able to differentiate between CHF and COPD. So they were observed for critical actions, including elements related to medical decision-making, ultrasound use, and interpretation. They actually found some really cool findings. Most of the students did attempt to use the ultrasound during the case. However, they did find that many students struggled with kind of the clinical application part of it. So this might provide some insight into this kind of preliminary type of ultrasound and simulation. Maybe it really helps them understand the images and interpretation, but they did struggle with clinical application. So maybe we can go a little bit further with this. The next kind of ultrasound simulation device that has been created, in which we've probably all had some experience with or some exposure to at least, is the Blue Phantom. So this is known as a low fidelity simulator, basically defined as something that's able to show you some simplified anatomy, usually not more than 1 or 2 vascular structures or nerves. And it's really designed for kind of the user who has some experience already, but wants to put in the reps essentially to get better at, for example, in-plane vascular access. This is another example of kind of a low fidelity simulator, a little bit higher fidelity than just simply the Blue Phantom, but a company called SonoSim has this kind of almost like gel pad that is able to be integrated with their proprietary ultrasound probe that's plugged into a laptop. And then based on what case you're doing, it can show you different structures. So it's kind of a cool way to use like only really one limited piece of equipment to show multiple different structures. And it's kind of in that mid range out of the kind of cost scale of these simulators. So in summary, low fidelity simulators don't really simulate external anatomy very well. They generally only simulate 1 or 2 vessels or nerves, but they do have the advantage of being lower cost. So then we move into some high fidelity simulators, some of which Sophia talked about during her presentation. This is an example of a simulator where the probe is connected to kind of a laptop, but you're able to scan through a model, which does simulate some external anatomy a little bit better, and then kind of showing you the images on a separate screen. Sophia talked about the Heartworks TEE model already, which is much more kind of higher fidelity. And in my opinion, the higher fidelity simulators are best used in these cases where they don't happen every day, right? You don't do or see a TEE on every single ER shift. And so outside of really practicing this in the operating room, this is the best kind of case scenario we have to get good at TEE. And so in my opinion, the low fidelity simulators and the high fidelity simulators are kind of best used in those more rare applications. Something like echo or something like lung ultrasound, you can just show up in the ED and do as many lung ultrasounds or as many echoes as you want. And in fact, I think it gives you better training doing it that way, because you do get the difference in anatomy and the variance and kind of some training in practicing with limited body habitus and other sort of anatomical variants as well. So something like TEE is where I think simulators really shine. And so to summarize some high fidelity simulators and their benefits, they do show you some precise anatomy, specifically external anatomy. They allow you to visualize what you're doing a little bit better in the whole sense. They can show some of the surrounding structures as well, but they do come with a much higher cost. So as you can see, this is just a screenshot just taken from yesterday from a company's website known as CAE. Here's a central line training model for almost $6,000, a femoral vascular access model for $4,500, and a tap nerve block ultrasound training model for around $4,000. So they really do kind of run the gamut of price here, but they do tend to be on the kind of higher end. And because of that cost of simulated models and commercial simulated models have risen the kind of homemade model, and some of us probably had experience with these as well. People have been publishing for the last 20 years on all sorts of types of different homemade models that allow us to practice point of care ultrasound. Ballistics gel has become kind of a favorite. The combination of gelatin with Metamucil has also become kind of a good simulator for the echo texture that certain soft tissues have. I've actually personally made a tofu model with kind of those long water balloons, put them on a chopstick, and then just kind of guided them through a tofu model to simulate vascular access. And then some people have also used things like bologna and sausage, and you can see somebody practicing in-plane vascular access on this tofu model to the right. And if you just type in ultrasound homemade model on YouTube, you'll find countless examples of how to make these. This is somebody making a ballistics gel at home in a cake pan, and you can kind of see what it looks like on the right. So not so bad. These are limited sometimes because once you kind of pop that balloon or glove or whatever it is, the latex structure, they do tend to lose their value pretty quickly. And so they're best used with their first probably 5 or 10 passes. But they are cheap and easy to make. So this is a comparison of a high fidelity to a low fidelity simulator. So as you can see, the high fidelity on the left shows you the structures that are around the vessel of interest, in this case, the internal jugular vein. So that might help someone learn about what's around there and what to try to not hit. Whereas the bologna sausage on the right kind of shows you the comparison. So they each have their pros and cons. This is just the same, taken from the same paper, the same sausage versus high fidelity model of central venous access. they made the point in this article to say, well, a low fidelity phantom such as this one made out of this sausage can actually be easily upgraded to create a more realistic experience for the candidate by attaching it to a more lifelike mannequin. So they've just put the sausage on the shoulders of a mannequin and covered it in a blanket, which I guess you could do to try to help simulate the procedure a little bit more. And then there's the world of 3D printed models. So these have a high upfront financial cost. They also have a high upfront time cost because of the time it takes to kind of really engineer the model and create the code to print the model. However, once you do have that code and that information to give to the printer, that's why it's really an upfront cost. And once you've invested, your institution has invested in a 3D printer, you can make many of these. They're easily replaced. And so this is an article from 2018 from Penn State, and it really makes me feel makes me think about what I was doing as a medical student. But this medical student out of Penn State has created a proprietary 3D printed ultrasound phantom to practice giving ultrasound guided knee injections. So they really, he actually wrote the code for the knee joint there that you kind of see on the right of the image, and then covered it in some ballistics gel and was able to kind of create this proprietary model. So, and just looking at the ultrasound screen over there, it looks not bad. You can kind of see it in the background of the image. And then come cadavers, the kind of last thing we'll talk about. These are pretty high cost and limited availability, so you really do have to be at a big institution for to have access to cadavers. We are very lucky to have access to cadavers here at Loma Linda, but many institutions are not, and so this doesn't have as much generalizability to the kind of community as some of the other models. So the last thing I just wanted to share about simulation before we get into some of the higher level learning concepts. ASEP, if you just type in ASEP simulation ultrasound, there's a whole subcommittee of the ultrasound section, and they actually have 3 links that are shown here. They have one link that's an Excel file for high and low fidelity simulators, comparing their pros, their cons, their costs, and everything else. And they have listed every single proprietary simulator, which is pretty helpful. They have a list of homemade ultrasound simulators, and they have things ranging from ocular to biliary to OB, and how to make different homemade ultrasound simulators in each of those realms. And then they actually also have a 3D printing guide, which kind of helps the user set up 3D printing and also helps them, puts them in touch with people who can kind of help create the 3D printing model. So I thought that was a nice resource to know about. Okay, so what about patient models? This is kind of the last thing. So they're low cost, they're readily available, they're much more realistic than any simulation could ever be. And they do show that variance anatomy that I was talking about, variance in body habitus, but they are limited by the fact that obviously we're not going to go around poking our patient models with needles, so no procedures. But this is why simulation really shines for things that are more invasive, like peripheral access, central access, nerve blocks, TEE, and even some transvaginal simulators that are out there. So kind of my own personal philosophy that I talked about already. I think simulation probably isn't the best for non-procedural modalities. I think it's to get a good look at looking, to get good at looking for the aorta, for example. You can't simply scan your medical student and resident peers who are statistically more likely than our patients to have normal anatomy, lower BMIs, et cetera. You really have to go out there, and there's actually literature that supports going out there and to become a quote unquote expert at aorta ultrasound, at scanning higher BMI patients to make sure you're not missing these aortas. So just one example of how I think probably just picking up a probe and going to the ER for non-procedural modalities is maybe still the leading way to learn that stuff. So does simulation work? So what about see one, do one, teach one? This is probably not the best way, as as we probably all have experience with, probably not the best way to learn how to do procedures anymore, especially with the wide variety of simulation that we have access to. So this was a study published in Critical Care Medicine called Simulation-Based Mastery Learning Reduces Complications During Central Venous Catheter Insertion in a MICU. So again, kind of supporting the procedural side of ultrasound simulation where we find the most compelling evidence. They actually trained medicine residents on central venous ultrasound line trainers, and this was way back in 2009. They found that it was much better in terms of outcomes, in terms of morbidity and patient harm. And so just kind of one of the best evidence studies that we have to support this. And then just to go over a few concepts before we wrap up. So emergency ultrasound really has three parts in terms of expertise and mastery, in my opinion. So the first is kind of a firm grasp of the indications. So the trainee knowing when and where to scan. The second part is image generation with interpretation. So generating the scans and knowing when the image is adequate to interpret and extract the data from. And then the third is kind of integration into clinical care. So this is kind of that part, and that's that initial study we talked about where the medical students were kind of struggling into integrating into clinical care. So basically making decisions based on all the data as a whole. So not only the ultrasound, but also the H&P. And how this kind of fits in with ultrasound and simulation is best viewed through the lens of some of these higher level learning concepts, one of which is Bloom's taxonomy. So this is basically a way to categorize educational goals. These action words basically describe the cognitive processes by which thinkers encounter and work with knowledge. And so utilizing simulation in point-of-care ultrasound and vice versa, using point-of-care ultrasound in simulation kind of helps us remember the indications on when to do ultrasound, kind of works, understand and practice image generation and interpretation. So kind of working our way up the pyramid, and then hopefully apply it to clinical care. So we're, as you can see, it helps us recall the facts and basic concepts, maybe explain those ideas, apply those to clinical situations. And then as you get kind of higher and higher into the pyramid, maybe even drawing connections among ideas. Miller's pyramid. So this is basically a check into how your learner is, how competent your learner is at the skill that you're assessing. So in this case, point of care ultrasound. And so simulation really checks into the shows how box here. So cognition is first tested at the bottom of the pyramid, tested by written exams. Do they have the knowledge? You can just simply do multiple choice questions to assess this. And then comes the know-how. Do they really know the way to clinically problem solve? And then next is kind of the demonstration of clinical skills. So testing by the OSCE, by standardized patients, clinical exams. And in my opinion, you can use simulation in this kind of part of this pyramid to assess competence. And in my opinion, assessing competency is not really a one-time event. Seeing a trainee perform a skill like point-of-care ultrasound in one instance, I think is insufficient to say that they've achieved competence. And so that's why assessment of competence requires kind of thoughtful assessment of several instances, hopefully simulated and real-life instances, ranging in complexity. And this is kind of where simulation offers kind of a window into assessing when they decide to reach for the transducer. And I think if you integrate simulation into a case, you're kind of getting all of these different pillars in one. And so to kind of articulate that a little bit better, you're not only assessing how they do the task. So using one of those vascular phantoms, all you're really able to assess is how are they at in-plane vascular access. They're just getting the reps in, they're just doing that one task. But if you do involve that into a case somehow, you can really assess when do they decide to reach for the transducer? How do they hold it? How long do they allow themselves to scan? Are they maybe scanning too long or too short? How do they interpret and integrate the findings into the care? So this can kind of serve as one of the many touch points, making the case for that trainee's point of care ultrasound competence. And I think eventually with multiple assessment points, you can really give them good feedback on where they are shining and where they can improve. Kind of last thing I wanted to talk about is Kirkpatrick's evaluation model. So this is really a way to assess the impact that the learning is having on either that trainee or the ultimate care of the patient. So kind of building this from the bottom. And this is basically assessed best with multiple surveys. So starting with the reaction, you can ask your trainees, or you can ask yourself, how did the participants respond to the training? And I think two-way feedback is probably best with this model. Learning, so how much did the participants learn from the training and have their skills improved? And this is kind of where Sophia's model comes in, is she's doing a pre-survey and also a post-survey. So this is kind of assessing that second level. And then third, like a higher level of this evaluation model would be, have they really applied what they learned from the training? So maybe taking a look at data and seeing how many of the residents have done a fascia iliaca block in 12 months from the conference day, from the training session. And then ultimately the highest level of this training model, or this evaluation model rather, is what benefits has the organization experienced as a result of the training. So that could be, are our patients receiving more holistic care? Are they receiving less pain medicines as a result, less narcotics? Are they having less morbidity as a result, maybe on the floor, especially when it relates to elderly hip fractures, for example, getting multiple doses of opiates. So a lot of the simulation literature does not reach this fourth level, and it hasn't shown really effects on morbidity and mortality yet. But I think as we all progress into this new world of high fidelity simulation and just more simulation in general, we can really show that it has an impact. And so I think that's it. I had one more slide just about the Kirkpatrick model again, but just a kind of a different way of assessing it more from a learning perspective. So did the learners enjoy the training? Did transfer occur? Did the training change behavior? And then did it influence performance? So you can kind of look at it through two different lenses, either the trainees or the patients. And that's kind of it, actually. Hope that wasn't too abstract of a lecture. We kind of went through the models, the pros and cons of each, and then talked about some learning concepts that apply to simulation.